right. So case number 1. 70-year-old female with an atypical lung carcinoid who was diagnosed in 2017. She underwent surgery at the time, had the left side of part of her lung removed, and the pathology came back as a T2NX, so no lymph nodes were removed at the time. M0, she had a CT, no other distant metastatic disease. It was a grade 2 tumor. The Ki-67 was 8%. Oops, told she was cured, which we commonly see. I guess it's the thoracic surgeon dilemma. We don't have any here, so we can just blame it on them. But she was told she was cured. And then a year later came back with a different problem, actually pneumonia at the time. And she had a CT chest that showed a pneumonia, but also showed new left pleural nodules, so little nodules that are lining the inside of the chest. And then also lymph nodes that were enlarged in the mediastinum, which is the area around the lungs. So you can see the CT, and this is just one example here. Where's the thing here? Does this work? I don't know. But the little arrow there shows you that there is a nodule there, one of multiple nodules that came back. So the question is, this was then biopsied, obviously, and showed that it was a recurrence of the lung carcinoid. And she had an FDG PET scan, not a dotatate PET scan, an FDG PET scan, but that showed no uptake. This was all done in an outside facility. And then she came to us. So what's the next step? Thor, you want to comment on this?
So for this, well, let's see if this works. Yeah. So for this one, I would like to see a gallium-68 dotatate PET CT just for completion of the staging.
So unfortunately, she's a Medicare patient. This is all real. Or fortunately, or unfortunately, I don't know how to say this. I'm taped, right? So I got to be careful here. But she's a Medicare patient, sure. and her last PET scan, so the FDG PET scan was 25 days ago, and you need 55 days until you can repeat a dotatate scan. So are you going to wait for a month, or is there anything else you want to do in the meantime?
So you could make an argument for waiting and just scanning again. You will need to know if there are somatostatin receptors on the tumor cell before you start somatostatin analog therapy.
So what's the likelihood, maybe like Dr. Lorisio, that if you have a negative FDG PET scan in a lung carcinoid, is it likely to be positive on a somatostatin receptor scan?
So that's kind of the prevailing wisdom, but that was a pretty small. That's a pretty small lesion, so you may be below the detection of the FDG PET. The other way to do, in answer to what Thor was suggesting, is to get the original tissue and measure it specifically for the receptor subtype 2, which it correlates crudely, but it's been shown to correlate with gallium and even with PRRT response. So if you have a good piece of tissue that can be sliced, the histochemical evaluation may be very helpful. On the other side, what Thor was saying, the patients are suggesting the patient had pneumonia, symptomatic. You know, in these cases where you can't avail to the SST2 stain, and you have to wait, I would empirically try, a dose of octreotide in this case.
So this was the question, right? Sandostatin or lanreotide. In the meantime, waiting. Let's not forget that before you do a gallium scan, ideally you would want to be off sandostatin or lanreotide for at least 3 weeks, right? So if you give your dose now, you got 30 days to go. That's great. But think about that if you want to scan as soon as possible. What about everolimus in a patient that has not tried sandostatin or lanreotide? Is that an appropriate treatment, or should we always try sandostatin or lanreotide?
So, well, I can take that one, and I'd love to hear from others too. So I think that's very appropriate. You can do that. So a lot of the patients on the trial that tested everolimus in lung NETs had not been previously treated with somatostatin analog, so you can do it. I prefer the somatostatin analog therapy because I think it's overall better tolerated, but that has not been tested properly in lung NETs.
Blaise, any insight on that?
So, I mean, the nice thing is we actually do know we get nice response with mTOR therapy in the lung atypical carcinoids. And, you know, side effect profile, I mean, everolimus is not benign. You know, fatigue, hyperglycemia, high hypertriglyceridemia. But I think in a patient who's symptomatic, and I agree, I'd be a little bit worried about giving the, you know, sandostatin lanreotide now, given the fact that we do want to eventually do gallium. That I think, you know, a 10 milligram Afinitor dose would be very reasonable at this time.
Okay, so let's
I assume that since
Dillon.
you haven't told us that she doesn't have any carcinoid symptoms.
She doesn't. No.
Right. Because that would have made it relatively easy to step to then test out a somatostatin analog with that as a readout for your
Absolutely, it's a great point. So let's talk about PRRT, and I know there are many patients I've seen and probably a lot of patients you have seen. So do we need a gallium dotatate before every PRRT?
Yes.
We do?
Yes. Yes, because it shows functional receptors, and it's highly predictive. They just did a large paper series from Basel, Switzerland, Walter, and he looked at the value of the histochemistry for receptors against PRRT and for gallium-68 against PRRT. And there's absolutely no doubt that the gallium, and that's what our PRRT tumor-board, Dr. Dillon chairs that, is predicated on. Because what we look at is not only that it's positive, but is it positive enough? And those SUVs that Sue alluded to, standard uptake values, are quantitative values in a lesion. And it's very important. And Thor can speak to his study on the lung tumor results that we did. You want to talk to the lung?
Very briefly, we looked at about 135 patients with advanced neuroendocrine tumors at the University of Iowa, and patients got all of them got PRRT, mostly with yttrium-90. And there certainly seemed to be some benefit in those, the small subset of patients with lung nets. And that is supported by evidence from Europe as well. PRRT definitely seems to work. It's just never been properly tested, but hopefully it will be.
And you need the receptors. So we were using Octreoscan early on, 18 years ago, but now we're into the gallium. And in fact, we do gallium with intent to treat. That's how we do the steps if we can. Is that, Joe, right?
We live in a real world, unfortunately, where PRRT's not been approved by the FDA for lung neuroendocrine tumors. So many patients that come to see us ask, well, how do I get my insurance company to approve it, number one? And number two, if I'm on Medicare, how do I get it approved then? Because as we all know, Medicare doesn't approve something. Medicare just follows usually guidelines. Some of them are like NCCN guidelines. We'll talk about it in a second. And we just submit basically the bill to Medicare and hope that they're going to pay us back. Yeah. So the hospitals, because anybody knows what a dose of PRRT costs?
Yes. $47,500.
About $50,000, right? So 4 doses is $200,000, and so it's a significant amount of money. And hospitals always cringe at us when we're like, "Oh, we got a patient. We're not sure we're gonna get reimbursed, but let's hope for the best." So that's usually very challenging. Anybody has any insights on this? Meaning, do we need to show that somebody progressed through sandostatin or lanreotide to get approval by the insurance company? Probably yes. Would everybody agree on that?
Well, the other thing too,
or everolimus.
Yeah, Sue alluded. So the Y90 protocol that she's maintained now for quite a few years is open for all receptor-positive neuroendocrine tumors. Sue, is that right?
Yes, that's correct.
which we have had the chance to treat also some thymic and lung neuroendocrine tumor as part of the extended access protocol, but unfortunately that's closed. So I can tell you, dealing with this over the last couple of weeks for a few patients, is our experience was that we do recommend to submit all the paperwork to the insurance company. It's a lot easier if you have progressed on sandostatin, on Riotide, or on like everolimus, because that gives us a good foot to stand on. And regarding Medicare, it's an interesting thing because we just ran this by some folks in the insurance department at Rush. So actually, what happens is that since it's PRRT is now part of the like NCCN guidelines, and it's a level 2A recommendation, every patient on Medicare with a lung neuroendocrine tumor will have most likely PRRT reimbursed by Medicare because it's a level 2A. Level 2B, Medicare will not reimburse, but level 2A they will. So I think there's a good, we're going to treat our first patient with a lung neuroendocrine tumor with Medicare next week. We'll see if we get paid. Hopefully we will. But there's a lot of therapies like immunotherapies, etc., that Medicare will pay off-label as long as the NCCN guidelines say it's a 2A. And Thor is on these guidelines.
Yes.
I had to take a screenshot of my computer because I wasn't able to copy and paste it because they won't allow me that. So maybe next year you can work on allowing patients to copy and paste things, because I wasn't able to. That's why it doesn't look very good. But anyway, that's an important point, I think.
Yeah, I did my first peer-to-peer for the Lutathera. It was a Medicare case, and I think the issue was not enough information they asked for, and then they approved it promptly.
So I think the bottom line is everolimus, like Blaise said, somatostatin receptors for lung nets, and then PRRT. Don't lose hope. I think we can probably get it for you either through the insurance company or if you're on Medicare through that, even if you have lung net and it's not approved.
So we have treated 2 patients with lung nets now. So since this became available to patients with commercial insurance, we've treated, as of this week, 45 patients at Mayo. So we have the payments are starting to come in, but so far hasn't been any issue with Medicare.
Yeah.
So that's good to know.
The other thing as we talk about this, to note, if you look at the schema, and I didn't bring it up and I apologize, those arrows go both ways. So what we try to do is, when we talk about therapies, they're all good, but the good one at the wrong time isn't the best. And so we try hard when you do a therapeutic option that you don't lose it in the process. And this is one of the best examples. I think chemotherapy or the anti-angiogenics, I look at them as bridging therapies. And if you think about it, as Xavier pointed up, we're just getting it in the United States. People have been around the horn on those. As Sue said, you could check them off the boxes. And so we have folks that have had that cumulative effect and now are ready for PRRT. And I think Joe would attest to that we see kind of the toughest of the tough right now as we go through to see if we can qualify.
Right, there are a lot of people in the U.S. particularly who've been waiting for PRRT for a long time, so they have been exposed to a lot of different therapies, and many of these therapies and the tumors themselves, of course, take a severe toll on their liver function. Sometimes on the kidney function as well, or on their bone marrow. So we sit for a long time discussing people in our tumor board as to whether a person who has been in this state of waiting for PRRT in the United States, whether now that it's available, whether it's going to prolong their life or not prolong their life, just because of how delicate their health is at this stage.
There's been not several, but I would say cases in the PRRT where we've actually backed them out. Dr. Haub attending has helped us seek another option for our folks, like targeted or cytoreductive surgery. And so this is an invaluable instrument, namely a PRRT board, because if you have your surgeons in pathology and radiology, nuclear, you can help greatly with surgery present.
I think that's very important. Right treatment at the right time, right? So you want to add something to that?
Just say a few words about children with lung neuroendocrine tumors. If you go back to think about that pneumonia, I bet they didn't culture any organism. probably, you could show it was not a viral and not a bacterial pneumonia. That it turns out that a non-organism related lung pneumonia is the most common presentation of neuroendocrine tumor of the lung in children. And we've had kids come in who've had 2 or 3 pneumonias with no organism cultured from any of them, even though they're all treated with antivirals and antibiotics, and they turned out to be neuroendocrine tumors. Right now, they're not allowed to have Lutathera, anybody under 18, so that gets into an insurance company too. But AAA is sponsoring a phase 1 trial for children. So from 6 years old to 18 years old, we're going to be starting one as soon as we get the FDA approval, and it'll be nationwide.
Great. Next case, a 55-year-old female with a pancreatic neuroendocrine tumor diagnosed in 2014, underwent at the time a distal pancreatectomy and a splenectomy. Pathology was T2N1, so some lymph nodes involved, no distal metastasis, grade 2, Ki-67, 3%. Oops, sorry about that. Then she was lost to follow-up. And then she presented to her primary care physician in early 2018, so about 4 years later, with abdominal bloating and discomfort. A CT was obtained, and this is what it shows. A massive tumor on the right side of the liver, taking about probably half of the half of the liver. You could see here in another dimension. And then also another tumor here on the left in green. That's the one on the right, and that's the one on the left in green. And we come back to the scheme on what to do next, right? So what are the possible therapies? Next step. Dr. How about that?
Trying to figure out where that thing on the left side is coming. Is that caudate or is that?
No, it's actually not caudate. It's a segment 4B lesion that's hanging away from the left portal vein in the pedicle. So it's resectable.
So yeah, I mean, hypothetically, you could do a right hepatic lobectomy, and if that tumor wouldn't require taking out the blood vessels to the left side, you could take that as well. So I mean, but it's probably worthwhile getting an MRI and just making sure there aren't a bunch of other lesions in the left lobe of the liver before you embark on that. You could also shrink those tumors with embolization.
So I would have liked to have Riyadh comment on this here. Do you think, Dr. Howe, we can shrink this with embolization and then offer surgery? Is that an option? Have you done that before?
Yeah, I think it is an option.
Okay.
Just a question.
Yeah, sure.
What was the size of the original tumor? I missed that.
The original tumor size was a T2.
Oh,
So I don't know the exact size, but probably around 2.5, 3 centimeters.
So around that 2 centimeter cutout.
Yeah, not very large, but she was lost to follow up for a long time. So lucky us, we didn't get to our radiologist, but we actually took these things out here. So this is the CT scan after resection. So you could see there's no more tumor left. We did get an MRI, Dr. Howell, just to make sure there was no other lesions. There was one smaller lesion a little bit higher up in 4B that we just wedged out. So, when you talk about surgery, should we, and if you're a surgical candidate, should you get a dotatate scan every time before like any operation? Dr. Doricio, any comments on that?
See, and I'd like to hear Joe's view too, but there's a place in Kentucky that uses, the way he talks, it's 3 or 4 gallium scans, not probably 2 a year. And we have to be very careful of that, because if you have a PRRT set up, and we do, then having the gallium in the same state as when you're treating them, it becomes important, because otherwise you do an intervention with this gallium and then an intervention, and then you're talking about PRRT and all the anatomy has been changed. And so we tend to use the gallium in the same state as the patient is in when they're going to go to therapy.
Jim, let's say you get a dotatate and it shows some bony metastasis. Would it change your management? Would you say the patient should not get an operation with such a large amount of tumor disease, but that we think is surgically resectable?
Well, I think the bone metastases are probably not a threat to the survival of the patient, whereas the liver is. So in most other tumors, that would be a contraindication, but for neuroendocrine, it would not.
Yeah. And you know, Larry Coles said something several years ago, and he's kind of like the guru from Mayo Clinic in the original generation on Sandostatin. But he was, I think, the first to say that if it's in the bone or if it's in the lymph node, the significance is no different. And I think what he was saying at the time was that immunologically the body doesn't recognize this as foreign. It just doesn't. It lives in the bone, and I think Manisha Shah showed that the fracture rate is less than 0.5% in a large series of fractures. It lives in the bone, it lives in the liver, doesn't react to the liver. And that's why transplants are so hard to get, because they can have a lot of burden and not make the liver failure scores. The liver function studies stay normal.
Blaise, do you think that PRRT would do something in this patient with this supersized tumor?
So right, this gets into the question is we don't know. We don't think it works. You know, the assumption is that it doesn't work quite as well with very, very large tumors. I think it's reasonable. But the other thing you didn't put on the list here, these are large tumors, but of course it's CAPE-10 in a pancreatic neuroendocrine tumor, where we can sometimes see fairly dramatic responses with CAPE-10.
It's right there. I didn't forget you.
Oh, I thought you were forgetting. I thought, that you were blowing us off.
Go down there.
Yeah, it's on the list somewhere. Yeah, but
somewhere on the list.
But that's, in my pancreatic neuroendocrines, I often have that pretty high where we need, where you guys need some at least.
Do you see shrinkage and then surgery afterwards?
Right. We can see some deep responses with CAPE-10.
Okay. I think that's helpful. Do we have time to go through the last one very briefly? It's anybody motivated to hear about it? Yeah. All right. Yeah. So next case, Jim is. That's good. Case number 3. We're still working on it?
Oh.
There we go. All right. 45-year-old male with a small bowel neuroendocrine tumor in the distal ileum, diagnosed in 2015, underwent a small bowel resection and right hemicolectomy. Pathology is a T1N1M0, so grade 1, Ki67, 1%. Sounds pretty good, right, Jim? Mm-hmm. So, but unfortunately, 1 year later, liver metastases appeared, or maybe they were there but not seen initially. He's completely asymptomatic, though. So a gallium dotatate scan and an MRI was obtained. They showed no progression of disease over 1 year in the liver. So the dotatate was obtained in 2018. From 2017, nothing has changed. So that's what it looks like. What do we do next? Do we leave him alone, like Dr. Polite says, or should we go for, or said before, for another patient, or should we go for resection? It's a little bit of extrahepatic disease here, as you can see, a couple of lesions a little higher than the liver there, but not a lot. Most of the disease is in the liver. He's asymptomatic.
Well,
of course, the dotatate showed us bone lesion that we didn't know a year before, so you could argue it's progression, but we all know that probably it's not, because he probably had those bone lesions before. So we don't have dotatate to dotatate comparison, we just have a regular CT to dotatate comparison.
Yes, would you or Jim do some cytoreduction and then PRRT?
I would.
Or would we just consider somatostatin analogs, or perhaps even not somatostatin analogs, but so we do have, we are convinced that there is progress over the last year.
No, we're not.
No. Oh, okay.
We don't think there is.
Okay.
Yeah, that's one scenario. So no progression. Can we agree to observe? Thor?
We can.
Would you?
If there's no progression.
When they're that positive, wouldn't you just, knowing anti-proliferation, put them on an analog?
I would have been nervous a year ago, right? So
if I presented a little late, so
right. No. I mean, if I saw that when I see that amount of disease at baseline, those are ones I get a little bit uncomfortable watching and doing nothing, because progression can have a bad thing. But now I've got a year's worth of data where nothing's changed.
Right.
I don't know what your hurry is.
Okay. Fair enough. So I think we can argue to either observe or get maybe lanreotide or sandostatin. Now, same story, except that this time he hasn't progressed, but he's severely symptomatic. So first thing, we put him on sandostatin or lanreotide. We all agree, right? Yes. So, his symptoms, he's calling me back and he's telling me, that's actually the true story, but he's calling me back and he's actually telling me, well, I'm having a hard time, second week of sandostatin, the symptoms keep coming back. So really, I only get a benefit after 2 weeks, or for 2 weeks after the shot. So I asked the medical oncologist to see whether she can get short-acting sandostatin in preparation for surgery, because I'm telling him, well, I think I can take most of these tumors out of your liver. But then, that's what he does. And would anybody agree? Is there anything else you want to do except short-acting for symptoms? Would you take him to surgery? Jim, would you take him to surgery?
Well, for symptoms that are breaking through sandostatin, I think you can make an argument. If
For
he was
reduction.
asymptomatic and hadn't progressed, I agree with the scenario of possible observation. I think, with symptoms, I think you can give him an immediate benefit through cytoreduction if he's a good candidate.
Blaise, what do you think?
Well, I guess this is where we get in the question of, what about, Y90
Right.
and doing, radioembolization in a case like this instead of taking this patient, for a non-curative surgical resection. Obviously, we don't know the answer, but, I would certainly consult my interventional radiologist.
And hopefully your surgeons.
I always hear from my surgeons. They
talk too much,
That's
right?
never a problem.
But you know what the answer is you're going to get from radiology. Yes, we can do it.
Yeah, the radiologist can always shoot something somewhere in the liver, right?
Well, I think this is one of the important reasons that you need a multi-specialty tumor board
Completely
to
agree.
discuss these folks all together.
Absolutely, and where your interventional radiologist is present too, I think is very important. Absolutely.
Well, and you
Dr.
raise-
Dillon is 100% right. So, we actually resected him, bottom line. This is what it looks afterwards. These are some ablation and resection. And this is one of those patients that was red before, really chronically red in his face before the operation, and afterwards he turned so white that his family thought we lost a massive amount of blood during the surgery, but we didn't. It was just the fact that suddenly symptoms were aware. This was about 6 months ago. I just saw him, no new progression in his liver. He has some tiny liver tumors left, but he's off sandostatin and off lanreotide. Now, is there any role in a patient like this to put them after you have reduced them, the symptoms are going away? Should we continue the sandostatin and the lanreotide just to hope that the tumor is not going to grow back?
Well, go ahead, Joe. Do you want-
Dr. Dillon?
I think I would keep him on sandostatin. I would keep him on a somatostatin analog. You've shown already that he has somatostatin receptors. He's got a gallium positive. I would put him on somatostatin analog to decrease his progression rate based on the studies.
Well,
that
and
have shown
especially
that.
since he had, he had symptomatic, he was flushing.
Right.
Why wait? That's
Well,
going to
you may
happen.
not believe us, but actually all the flushing went away after the surgery.
No, I know, but it will happen.
Yeah, sure
but we know it will happen again.
Correct.
So why?
Yeah,
why
and he
wait
has
for-
extrahepatic disease, right?
Yeah.
Let's not forget, he still has a couple
Right.
of bone lesions in the bone, right?
So here I think it's easy. But Dr. Ariso, would there be, so he's on sandostatin LAR, he's getting, benefit for 2 weeks. Is there any role where you think lanreotide, given, could be beneficial in that case, or?
There is, and I've not observed many, but I've seen that when the octreotide LAR starts to wane or become ineffective, and you give lanreotide, you can get a longer part. But I always use, when you're in a normally high dose, like let's say 30 milligrams a month, if you give the sub-Q, the question we ask in this kind of a case is more better. And that you ask the patient to take 100 micrograms 3 times a day on a regular basis, and you see how long or how much it takes over a week to keep his symptoms or her symptoms down, and then you calculate for the long acting. In this case, I think first trial to switch over is reasonable, and I think Joe has experience that way as well.
I would agree with that, and changing to lanreotide is one possibility for a potentially longer action, but going up to 40 milligrams or 60 milligrams of sandostatin LAR would be another alternative approach. But like Dr. Odorizio, I do give people a trial of short-acting octreotide to see if some of their symptoms are carcinoid symptom, truly carcinoid symptoms, and how much it would take to control those things. I find that helpful clinically.
So-
Remember the profile on the short sub-Q goes very high in 30 minutes, plateaus for an hour. So if you have an effect, it's almost causal
So
improvement.
Should we give this patient PRT right off the bat, now that we've taken most of the tumor out of his liver and we think that he's not in acute danger of progressing rapidly in his liver anymore? He does have a couple of lesions in his bone. Do we need to pull out the PRT gun right now, or can we wait a little bit until he progresses again?
So
Any
no
questions?
evidence. Personally, I would hold off on that. This is a long distance race. You're
Right,
not going to
he's
cure him
45
with
too, right? So
you're not going to cure him with PRRT either. So again, using up one shot at the PRRT at this stage when he may just remain stable on somatostatin analog for the next 3 years, and there'll be even better PRRT then.
So maybe keep the PRT in your back pocket for when things are progressing, not use all your bullets at once. I think that's a very important thing that I think if you go to experienced neuroendocrine tumor centers, this is really what we will try to make you understand. There's a lot of very exciting things nowadays, a lot of very exciting treatment options, but we have to use the right one at the right time for the right person. Okay, should we answer a couple of questions, Laren? All right, so would a patient who receives radioembolization be a candidate for PRRT if they progress? We talked about that briefly before. Any thoughts on that?
Sue may want to comment. There's 2 papers now looking. The best one is the one because it's Lutathera that's now acceptable in Europe. It's FYI, LU, no PRRT was ever approved as like the FDA approves a drug for 20 years. But so they've studied now the Lutathera with PRRT Y90. They use a different energy, Y90 spheres. And it's a fairly large paper, and it's a German paper, but there does not appear to be a downside to the combination. Remember, the energies are a little different. When you give Lutathera, it's a softer beta energy, whereas the Y90, as Dr. Salin pointed up, it's a scale, it's 2 or 3 scales higher when you give it straight into the liver. And so they do take a heavier hit, but it does not appear to be deleterious. But that's the one most recent paper was last year.
What to expect after PRT? There's a growing number of patients having or getting it. What happens next? I'm not sure what that means. Like, what happens next is what is next in the pipeline. Maybe that's the question. What to expect on the next scan? Oh, okay, I guess. What to expect on the next scan? Will the carcinoid syndrome or symptoms subside? So we talked a little bit about this, right? The objective response rate, the chance your tumor is going to actually significantly shrink is about 20 to 30% with PRT. It depends, I guess, a little bit. Perhaps we don't have enough data to know whether there's a difference between different types of primary tumor. Maybe pancreatic respond a little better or worse. We're not quite sure yet. We just know it works in most tumors that have somatostatin receptors. And then, will it help with symptoms? Will the PRT help with symptoms? My experience is yes, actually. I've seen many patients that feel a lot better after, in terms of flushing and diarrhea, after they get the first PRT cycle or the second PRT cycle. Is that your experience on the panel?
It is. We've seen there seems to be 2 mechanisms. As you know, not all of these tumors are functional, but when they are functional, it seems to be a different apparatus in the secretion of the hormone versus the nature of the tumor itself. And they do uncouple. We've seen some terrible high calcium due to a hormone respond with the PRRT. I had one person who went a whole year without any more high calciums just with the PRRT, but the tumor, was stable, but it wasn't as powerful as the symptom control.
So that's, I think, important, right? An important point. It's not because your tumor doesn't shrink that your
That's
symptoms
right.
can't get better. I think that's a very important point.
Yeah.
We obviously would love for the tumor to shrink as much as possible or even disappear, but the truth is that it's not because it's not shrinking that your symptoms can't get better. That's important. Doing PRT Why get a sandostatin injection within hours of the PRRT? Wouldn't it compete with the binding of the PRRT? I have extremely intense receptors. That's a great question. Who wants to take that?
You want to do it, Joe? Okay. So the argument is, and we heard something about the lutetium, I think, from Dr. Paletti, and but the mechanics of this is like, it's like almost a first pass. When you get the PRRT, you have a few keys, radioactive keys, against thousands of octreotide keys that aren't labeled with radioactivity. And that's been a real problem because some of the German centers say, oh, you can give the cold, that is the unlabeled somatostatin, and keep it at a certain low level, and then give sort of like you're quenching the normal, turning down the normal, and allowing the high expression tumors to receive. We just don't do that. We want it clean. We want no octreotide. We have used as soon as within 2 hours on a VIPoma patient, and we've done it before with a carcinoid crisis, because rarely you can get crises with these carcinoids, but within 2 hours of finishing the infusion, we have started the octreotide. Now there's two ways to look at it. It might shut the radioactive material that's in the tumor. It'll keep it from leaking out, which has been shown with I-131 therapy and thyroid. But the bottom line is, and I think you mentioned it, Xavier, that you really do clear, no, I think it was Dr. Paletti, you really do clear the lutetium very, very quickly. I mean, it grabs onto those cells and it's taken inside the cell within an hour or two. The fact that you can measure it, they measure it for days. You can measure, the half-life is six days for lutetium. 10 half-lives is a clearance. So imagine that 10 times 60 days, it takes 2 months to get the damn stuff out, you know? And so, but the key energy is expended in the 6 days. You use almost all the energy of the radioactivity. So it's pretty much done its job the minute it's in.
So it's appropriate to give PRT the day after, or within 24 hours.
Very
after
much
PRT.
a day after, very
Yeah.
much the day after.
So last question, patients who have been through multiple PRT rounds overseas, how do they figure into a conversation for domestic treatment instead of a repeat travel abroad? We all love to travel to Europe. Europe was a great place, especially Belgium, I would say. But that's where I'm from, so I'm a little biased. But I think I would just encourage, and I think we can all agree on that. So the question is whether, if patients already had some rounds overseas, now that it's approved in the US, how do they get back to us, and can we treat them here? Absolutely yes is the question. Like is the answer. I would like really encourage all of you that are in the situation, unless they want a vacation in Europe, to really come and see us. And you know, there's multiple centers in Chicago, there's University of Iowa, Mayo, you know, plenty of good centers and great centers in the Midwest that can offer that. Reach out to us and we'll make sure it happens for you.
And see, I think the one thing we didn't discuss was sort of retreatment, and you know, at least the current labeling suggests that people can get up to 1,600 millicuries. Yeah. So, you know, depending on how much they've gotten, we could also retreat. Again, I think probably Dr. Mauricio and crew have more experience, you know, with these multiple treatments, but at least that's how it's labeled.
I think it's a very good point.
Yeah.
Sue?
Actually, this has been looked at quite closely in Europe, mostly in Holland, and they have shown that you can recover enough reserve in kidney and bone marrow to be actually able to go second round of 3 or 4 treatments of lutetium after you've had the full 800. But the consequence is that the amount of hematopoietic dysfunction increases. So it's actually more a bone marrow problem than it is a renal problem when you retreat.
Yeah. The other thing was this idea, if you've had lutetium and then down the road get yttrium treatment, or you've had yttrium first and then down the road you get lutetium treatment, that it's like a 1 + 1 = 3. This was the retrospective study from Basel, Switzerland, with Damien Wild. And I think it gave progression-free survival of an additional 2 years. That was there's only been one paper on it, and I think it was 480 patients. But people who have had, for the first 10 or 11 years, PRRT was done with Y90 in Europe and then toggled to the lutetium. But if you have one and then the other, or the other and then the one, you can have, and again though, you run what Sue is saying, because Y90 is a bit more toxic to the kidney than the LU, but the LU is more toxic to the marrow. It behaves like iodine 131 in terms of its energy and its predilection for the bone marrow.
Thank you very much. I hope this was helpful to you. Thank you very much to all the participants on the panel.
Thank you.